Je vous propose de commencer. Bonjour à toutes et tous.
Good morning, everybody. We're going to begin the first session today on eating disorders and food addiction. My name is Mélina FATSEAS from Bordeaux. I'm a professor of psychology and addictology, and it's a great honor and a great pleasure to chair the first session of the day. That we're going to begin with the first speaker. I also have a lot of pleasure in welcoming Professor Blandine GATTA-CHERIFI, who is a professor in endocrinology and nutrition at Bordeaux University, and she's also responsible for a specialized unit in obesity in the Bordeaux University Hospital. And she's going to be talking about drug management of patients suffering from obesity and eating disorders. Thank you, Mélina. Thank you. I'd like to thank the organizers for the invitation. I'm the endocrinologist and nutritionist here today, so I'm going to be focusing more on my practice of the management of obesity and say a word about eating disorders in this situation, and perhaps we could then discuss the issue. I thought it was important for me to recall that we're talking about something which is very topical, an issue that we all share, whatever our practice is. We are confronted with an epidemic of obesity throughout the world. It's very simple. I think this is the weight of figures here and the shock of the colors. The redder it is, the more obese you have. This is between 1975 and I think 2022. An increasing number of countries have become red. Some have even become black. And this is a very concerning situation. With regard to 95, the world prevalence of obesity has increased by 155% in men and 100% for women. Some regions are more concerned than others. And if we continue in this way, by 2050, more than half of the adult population in the world will be suffering from obesity or overweight. So whatever the activity one has in healthcare, we're going to be seeing patients suffering from this disease. And it's true for France as well, where the situation is not much more reassuring. We have some epidemiological surveys which are carried out more or less on the same methodological basis since 1970. It was called OBP at the time. Now it's called OFEO. But whatever the name, these are studies which look at the adult population in France. It's based on questionnaires. In 1997, there were 8.5% of the adult population suffering from obesity. Today, the average, the national average is 18. And if I look at the southwest, unfortunately, the local cuisine doesn't protect against this epidemic. And for the first time, we have figures concerning the overseas territories, which are concerned too above the national average, with 22% of individuals in the adult population suffering from obesity. So what are we talking about when we're talking about obesity? We're talking about a disease. Again, this is something which needs to be recalled sometimes to our colleagues, to healthcare professionals and patients who are not aware of this. And it does them good to hear that it's a disease. And this is not an invention. It's the World Health Organization recalls that obesity is a disease and recognizes it as a disease because it challenges the physical, psychological, and social well-being of individuals. And it's also useful to add that it is a complex, chronic, and multifactorial disease. And all of these words have their importance in management, including drug management of the disease. And this also is important that if you're talking about obesity, you're talking about an excess of fatty mass, which has negative consequences for health, and that reflects the current environment. It's beyond simply the question of weight, but beyond the the BMI, the body mass index, there's a lot of discussion about new definitions of obesity. Sometimes it might seem as sort of parish quarrel with different societies in different regions of the world, the Canadians, the Americans, and Europeans, and the French. They all have their own proposals to define obesity using other indicators than BMI. But this is currently an issue for reflection, and it's important in assessing and managing our patients. We're not treating a weight or a BMI, but a patient, and we have to see the complexity of the disease. And so we're not going necessarily to have a target that we need to get at any cost, but what we're trying to do is to improve the patient's health. And that, of course, comes back to this definition of the excess of fat matter, and that has negative consequences on health. So obesity is a multifactorial disease, lots of things involved, genetics, the environment, the microbiome, and so on, all sorts of elements that are involved, which will cause this imbalance in terms of energy intake and particularly modify feeding behavior, eating behavior. And I know I'm talking to here a population that is very aware of eating behaviors. But nonetheless, I thought I could say a few words about eating behavior. We are made physiologically to eat during the day and not at night, to eat at certain times of the day and not all the time, whereas our energy expenditure is continuous, our energy input is discontinuous. You begin to eat, then you ingest the food, and then you stop when you feel satiated, and then there's a period of time when you don't eat. That's satiety. That means the state where you are not hungry until the next meal. And at each of these phases, pre-ingestion, ingestion, and post-ingestion, you can identify or see behaviors. Looking for food is much more for the animal kingdom. But preparing food, the choice of food, or state of well-being after a meal, that's associated with sensations like hunger, the physiological need to eat, and then when you feel you've had enough. And then satiety is the situation of non-hunger, which should go from the end of the meal to the beginning of the next meal. This physiology of eating is essentially supported by a very important region in our brain, which is the hypothalamus, which regulates energy homeostasis, the balance of food in and energy out, and it's based on the notion of energy. It's physical and it's chemical. And of course, there are other regions which are also involved in physiological regulation of eating. That's the reward systems, and perhaps something which is less well known, but the role of cognition and particularly memory. So all of this governs a physiology for food intake. And then there are some times where it works less well, and particularly when you completely lose this homeostatic regulation of food intake. When you're no longer eating just at daytime, but also at night, you lose the signals and the feelings which are involved in bringing on hunger and stopping hunger. Sometimes you lose the time when you no longer eat during a day, and that can go to real eating disorders in the psychiatric sense of the term. And in situations of obesity, eating disorders that we can see most often is bulimia and hyperphagia. the prevalence of which has increased very much in the population suffering from obesity, much more than in the general population. And it's characterized by recurring crises of bulimia without any compensatory behavior, and that would go along with great distress. So once again, if I look in the position that I'm in, and that is as an obesity specialist, these eating disorders in obese patients, it's very important to be able to screen for them. And unfortunately, in 2025, this is not always the case yet. We can see patients where we thought we were assessing their eating behavior by counting calories and nothing more. It's rather sad, but that still happens. It's important, obviously, to go beyond calories, and these behaviors and these feelings that we have, we need to question them, challenge them. And I tried to teach this to other doctors working with outside the team. What is behind this food intake? When you go looking for food, are you necessarily hungry? But you have to ask them. Spontaneously, they're not going to say, yes, I had some food, although I wasn't hungry. That's part of the assessment. It's 1,000 times more important than counting calories. There are questionnaires that can help if you need to score things, if you need then to study them and so on. But the interview means you have to have time to carry out a semiological analysis of these eating behaviors. It's extremely important. It gives us a clearer idea of what we're doing and helps us to know what kind of management we could orient the patient towards. Until now, we had very little choice. It was just either changing habits or bariatric surgery, although we know it's contraindicated for patients suffering from eating disorders. Of course, you know now that there is a new therapeutic weapon, which is medication. But to choose, I think you need to have characterized the patient. It's not one form of obesity. It's patients' obesity. It's patients suffering from obesity who have different diseases and may have eating disorders that need to be taken into account so that they can be managed. So the revolution that we're living through, which has been on the front page of newspapers and even on buildings in the United States, that is, of course, a revolution. And it's a great opportunity for doctors who are treating these patients. The arrival of drug treatments of obesity, which today have a common base. This is the GLP-1 analogs, and there are other modes of action which can come along with this. There can be double analogs, triple analogs, but the common base is the GLP-1 agonists, which is a hormone secreted by the L cells in the intestine, in the gut, in response to food intake, and it has a role on regulation of the secretion of insulin, depending on the glucids in the mouth. And this is why they were developed, first of all, for type 2 diabetes, but they also have a role in regulation of food intake and gastric emptying. And that means that they then developed for obesity, and associated with that patients who have type 2 diabetes and obesity have impaired secretion of these endogenic chemicals, products, substances. So I'm not going to talk about all the studies coming out every day, every week in all the major scientific journals. Just 3 slides to sum up the effects on weight. The first drug was liraglutide, which is an GLP-1 analog, which is injected subcutaneously every day, which is called Saxenda under its commercial name. And so these are the first studies that we had some 10 years ago with Saxenda. We had almost 60% of patients losing 5% of their body weight. 30% lost 10% of their body weight, and a bit more than 10%, between 10 and 15%, more than 15% sometimes of body weight. That's how we express things now. We're no longer talking about kilograms of weight loss. We're talking about the weight loss as a percentage of body weight, because at each level of the percentage of body weight, you can match that with improvements or a complication of the complications associated with obesity. We know what we can win with 5, 10, 15% reduction in body weight. Beyond that, we don't really know what we're going to be able to gain. We do know what we're going to lose. But today, we're talking about percentage of body weight lost. The two other drugs which are now marketed are semaglutide, Wegovy, and tirzepatide, or Mounjaro. So to ensure there's no confusion, semaglutide is used both in type 2 diabetes and obesity, but they don't have the same market names. In type 2 diabetes, we can go up to 1 milligram per week, and it's called Ozempic. So when people have Ozempic, it's for their diabetes. And in obesity, it's called Wegovy, and you can go up to 2.4 milligrams per week. And if they have Wegovy, it's for their obesity. And there's a difference which is not negligible, that it is not reimbursed by Social Security in obesity. And tirzepatide is called Mounjaro. It has the same name, whether it's used for diabetes or for obesity, and it is not reimbursed either for diabetes or for obesity. These are weekly forms which give results in terms of weight loss, which are very interesting. I could show you here, just to look at this quickly. Look, a study called SURMOUNT-5, where comparing the two molecules, but this is not a randomized study. It's an open study. It's not a real comparison. So what you can see is that there is between 50 to 100% of patients who do lose body weight, between 40 and 60% who lose 15%, an average a third of patients lose 20% of their body weight. This is the order of what you get with bariatric surgery. Some patients respond even better, but this is not a comparison, even if you do have the impression that there's a little more weight loss with tirzepatide. It's not a controlled randomized study. Once again, we're not just looking at weight, and I'll say a little bit more about that in a moment. Of course, there are secondary effects, side effects, which are not uninteresting when you're talking about eating disorders. These side effects are essentially connected with the digestive zone: nausea, constipation, diarrhea, sometimes vomiting, between 15 and 20% of patients. These secondary digestive effects are all the less important if they're less important if you have prepared things well and if the patient is given appropriate support. And in particular, they're less important than if eating is controlled in terms of the fat content, if there are not too many lipids in the food intake, and if you respect the protocol for escalation of doses to come up to 2.4 milligrams per week, with stages every month that you can prolong if the tolerance is not so good. We can also see patients who have nausea, who sometimes just don't feel hungry. That's one of the mechanisms through which the drug acts. They vomit, and in a population which has eating disorders, of course, you need to be very, very, very vigilant. Beyond weight, there's a context for the management of obesity beyond weight. It is all the associated complications, and particularly cardiovascular complications. And there's a study here which is a reference for us. That's the SELECT study. These are patients who suffered from overweight or obesity, who were on secondary prevention after a cardiovascular event, who were randomized either 2.4 semaglutide or placebo, and we have a reduction after 4 years of 20% of the risk of a relapse of cardiovascular events in the group treated by semaglutide with regard to the group under placebo. And this comes in very soon. I was with some cardiologists yesterday, and I listened carefully to what they said. This comes in very quickly. And in this select study, where you had pre-diabetic patients, and that can be an obstacle to losing weight, the weight loss is about 9%. And you could say 9%. Patients might say that it's not very good. I've already done it 20 times at 9%. But 20% reduction in the risk of cardiovascular events. That's spectacular. It goes well beyond weight. There are perhaps other pathological events that we don't understand beyond weight. But this is the domain that we're in for managing obesity. And beyond weight, why not eating behavior? We have data from animals. These are rats with liraglutide. And we can see that when we treat these little rodents with liraglutide versus salt serum, you reduce their appetite for sugary sweet food and increase their appetite for kibbles or whatever it is. For the same thing with humans, you can see that there is an effect of the GLP-1 analogs that goes through something elsewhere, outside the hypothalamus, outside the region that is involved in homeostatic regulation of food intake. In this now quite an old study, the authors measured the concentrations, androgenic concentrations of GLP-1 after a meal in individuals, and then correlated them with cerebral activation after the food intake. And you can see that the hypothalamus is activated, and there's positive correlation between the concentration, endogenic concentration of GLP-1 and brain activation at the level of the hypothalamus, but also in the prefrontal cortex, which is not involved in regulation of food intake. Or this study shows that although in subjects suffering from obesity with regard to thinner subjects, there is hyperactivation of the regions involved in reward, like the insula and the amygdala. But these subjects suffering from obesity, if they're treated with exenatide, that's on the right of the slide, have a significant reduction of this activation of the brain zones which are involved in reward and pleasure. Exenatide is a GLP-1 analog. We have others. Liraglutide is the Saxena that I talked about a moment ago. It's a daily drug. This is here in human beings to see that it reduces the brain activity of regions involved in the desire for food and of palatable food. Semaglutide, which is the form that is used now, it's the weekly form. We also have some scientific evidence to prove the presence of receptors and activation of these regions after injection of semaglutide in the hypothalamus, but also in other brain areas. And when we look at, this is quite old data, when you look at this was the first poster with semaglutide. When you give semaglutide to individuals suffering from obesity, they reduce their weight, they reduce their food intake. When they're presented with a buffet, they reduce their hunger, so beginning to focus on their food intake. They increase their satiety. They reduce their interest for looking for food. Are there some randomized studies that have focused on these symptoms, such as craving, essentially craving? They're beginning to emerge. There are some studies whose main goal was not to focus on that, but in the main goals, they collected that type of elements. 55 patients on tirzepatide, 15 milligrams associated with management based on modifying lifestyle. We look at weight and some more metabolic elements, but also focused on eating behavior with two questionnaires, the food preference questionnaire and the food craving inventory. Of course, they do lose weight. We know that. This was Montero. There's a significant reduction of the calorie intake, but above all, there is a significant reduction of the food preferences on most of the items that we've looked at: high fat, high complex carbohydrates, and a significant reduction in craving, both for all items and, again, also when you break that down into different elements, except for fruit and vegetables. We'll have the same type of response with semaglutide. This is the step 5. Step is the study of the development of this drug in obesity, but semaglutide in obesity. We looked at there's 2.4 milligrams of semaglutide versus placebo. We can see the weight loss, with 1/3 of the patients losing at least 20% of body weight. And when you look at what happens with regard to food eating behavior, we have a significant increase in the treated group with regard to the placebo group of control of craving, and we have a reduction in craving for different components of food in the treated group with regard to the placebo group. So this is populations of obese subjects that were treated by a GLP-1 analog, and we've looked at their feeling about food. The next stage is the eating disorder, eating behavior disorder. We have very little data. I found 2 studies in the literature. The first is a pilot study which was published 2 years ago with liraglutide, with patients who had a diagnosis of binge eating disorder, which was treated with liraglutide. And when you look at the number of binge episodes in the placebo group in red versus the liraglutide 3 milligram group in blue, there's no really significant difference. Another study using, again, semaglutide, it's a cohort study, a retrospective cohort study, where the patients were distributed into 3 groups. They all had a binge diagnosis. Those who only had semaglutide, those who had semaglutide plus a drug against binge eating, and those who only had the binge eating drug. And you look at the effectiveness on the score of the binge eating scale, which reduces significantly more in the group where semaglutide has been added to the classic binge drug, or semaglutide alone. Those are individual results in the 3 groups. This is retrospective. These are very small samples, small populations. So today, what we can say in what we're interested in today is that we have new drugs against obesity, which are effective, they're safe, they can mean that you can go beyond weight. There's very little data on their use in patients in a situation of obesity with bulimic hyperphagia. There are some things on the existence of receptors in the regions involved in food intake linked to pleasure, rewards. There are things on eating behavior, craving, food preference, but today we don't have sufficient data to say that there is some patients have eating disorders and obesity, and a lot of learned societies are saying that you need to be extremely prudent in patients, and of course, who suffer from obesity and binge eating but have other eating disorders in the past. You need to be extremely prudent where there are antecedents of restrictive eating disorders, and particularly with the side effects of the drugs involved. Thank you. Thank you very much for this very clear presentation, and it recalls very clearly, as you said, the overlap between eating disorders and addictive behavior more generally, and obesity, of course, which is of particular interest for us. With this data, again, which is very interesting, and some avenues for therapy now, which are new, and we can look at the impact of addictive behaviors. You talked about craving. There is some data. So a lot of studies are in progress on addictions, also with substance abuse. So just take a few questions now from the floor, if there are any, with a microphone. Good morning. Thank you for this excellent presentation and update. There are reports of cases of an effect on other consumptions. So the experience in the reference center of obesity, where you see, obviously, by definition, a lot of obese people. Amongst those who have this treatment for obesity, have you noticed, or have there been cases reported of changes in their consumption of tobacco or alcohol or other behaviors which are not necessarily considered as addictive, but which could potentially be so? Yes, thank you for that question. It's true that these are things which we have noted, and I have an idea. We were lucky enough to be able to be a center benefiting from to early access to semaglutide. That means that we were able to treat, like a lot of other centers in France, there was early access for nationality. Some people had severe obesity with complications, were able to be treated without having to pay for the drug. So that was the first steps with the drug. And I think in particular of a patient who was followed in your hospital, who had alcohol consumption, which was problematic. And she was followed up in the unit. She'd lost weight, she's managed, and then we lost sight of her, and everything was going badly for her. Weight, alcohol consumption. And she knew that there was this drug, and we said, we'll set everything in place again and discuss this. And we were a bit reluctant, and this is what she did. We set up the monitoring and follow-up, and then we said, okay, let's go. We can see her weight, which is getting worse and worse. But at the same time as she was being treated and there was a metabolic improvement, she reported an improvement in her alcohol use disorder and less interest for alcohol. So there are a few other cases like that. So there's data in the literature, but from there to say that that has this kind of effect all the time would be perhaps going too far. But for the moment, if we just look at eating disorders, which is what I know better, patients describe that they're no longer attracted by the same foods as they were before they began the drug treatment. And I think it would be interesting to be able to reassess all of those cases, perhaps in a retrospective study. But we have some experience that goes in this movement. Perhaps there's time for just one more. I have one more question. There are some other questions from the floor. A very quick question for people who have been operated with a bypass sleeve. There was a question at one stage about alcohol use disorder and obesity, and I was working with a team which used other drugs which have actions on compulsion and so on. It's a sleeve bypass surgery. No, there's no. With the arrival of this new drug. As we're not accustomed to having choice, we're all saying, well, bariatric surgery is going to disappear, we thought. So there was a lot of controversy in different obesity management groups. Is there still a place for bariatric surgery? Yes, we're glad that we have a new drug to treat this chronic disease, but it's not going to make the others disappear. If we look at the care history of these patients, we have patients who have a pharmacological treatment before bariatric surgery, not necessarily as a preparation, but you start there because you have obesity which is too great, or possible complications counterindicating surgery, or food intake and taking on weight if that was improving, the food behavior and so on. You can ask whether a pharmacological treatment of obesity, it doesn't contraindicate in either way, even if we don't yet have, well, I don't think we have, there are some studies. The other question was on uracil. I'm afraid I don't have an answer to that. I know about prescribing drugs and so on, but otherwise I call for help. Perhaps just one last question, I'm sorry, but we're going to have to move on to the next presentation. Last question. Thank you very much for this presentation. It was very clear, very instructive. Would it be possible to recall the modes of prescription? Which hospital speciality is it for outpatients? Today, since June, prescription is possible by any medical doctor for patients suffering from obesity. What else should I say? It's not reimbursed by the social security system, but it requires support, very clearly. The idea wasn't to look back at all the pharmacological treatment of obesity, but those of my generation or before know that we had some difficulties in the past, or even some catastrophes in the past, and we don't want the same thing to happen again. We want to be able to keep this drug, which is effective, and I think we need to behave properly, respond properly to it. I hope that we're going to do things well. There are some patients who don't tolerate it well. There are some patients who are just not hungry at all, so they need to be monitored. And this doesn't only happen at 2.4 milligrams, even at 0.5 milligrams. Some patients are just not hungry anymore, don't eat any protein, don't drink. So there are problems of kidney issues, severe kidney problems. So I think this requires support and follow-up by professionals, even if the prescription is authorized by any doctor. And you mentioned the issue of restriction, the history of restrictions. I think you need to stress that somebody who is obese may not have been anorexic or restricted in the past, but yes, potentially they may have been. And is there not perhaps a risk of, with those patients, or certain patients at least, have complications that can be observed in bariatric surgery, and a switch to anorexia and severe denutrition? So yes, and you have to be very careful. It's bariatric surgery which taught us that. Patients don't report this history of restrictive eating disorders spontaneously. So it does take time to analyze the weight curve and so on. When you see very important variations in weight over a lifetime, that usually means that something happened in terms of eating disorders. But it takes a little bit of time beyond the BMI. Perhaps really just a last question. I'm sorry, we're going to have to go on to the next presentation, otherwise the organizers are going to be unhappy. I just wanted some clarification on the study about craving with semaglutide alone and with the anti-binge drug. What was the anti-binge drug? There was topiramate and one that I don't know. Naltrexone? No. I don't know. Bivan? Okay, that must have been. And topiramate. And the results, it was significant when there was the association? Yes, semaglutide was better than the anti-binge drug alone, but semaglutide was better. But it was a retrospective study. Thank you. Thank you very much. Thank you once again for the discussion.
So we'll move now on to the second presentation. So it's a distance presentation given by José Manuel FERNANDEZ-REAL, who is a researcher of the University of Girona in Spain, and who has worked a lot on the role of the microbiota in food behavior and interactions with fat tissue and the brain. And she's going to tell us about the role of the gut microbiota in food addictions. Okay.
You can.
Can you hear me? Can you see my presentation?
You can speak now. Thank you.
Okay, thank you very much for your kind presentation. It is a pleasure for me to be here in this prestigious meeting, and I want to thank the organizing committee for this invitation. As you have said, I will talk about the role of gut microbiome on food addiction. I am passing the slide. I don't know if you can see the next slide. Can you see my conflict of interest slide here? I have no conflict of interest. I can see if the presentation is running. Okay.
See, it's okay. It's okay.
Okay, thank you.
Okay, you can.
There are many factors that are influencing our gut microbiome composition. One of the most important is the diet. Diet is critically affecting the composition of the gut microbiome. And this diet is influencing how these bacteria proliferate in our intestines, in our bowels. But which is the connection between these bowels, these bacteria in the bowels, with our brain? This is a matter of fact that has been investigated over the past decades. It is important to know that diet is influencing our brain, because the cells in our brain need a lot of nutrients, and the competition between the bacteria and these nutrients in the bowel is probably affecting how the brain works. I am a clinical endocrinologist, and I am worried about the diet in our subjects with obesity, and how the diet may modulate the risk to developing dementia over time. It is very well established how the modification of the body weight critically affects the risk of developing these impairments of cognition over time. It is very well known how in obesity, the cognitive function is affected. There's a decreased attention and decreased executive function. And at the same time, obesity is affecting anxiety, depression, a lot of cognitive mood disorders. We need to be conscious that in our intestine, a lot of neurotransmitters are also produced not only by our brain, but also inside the bowel. So these bacteria, reflected here, are synthesizing serotonin, dopamine, noradrenaline, these neurotransmitters that we, at the forehand, we think that are only in the brain. One of the examples that the brain is affected by the microbiota is how obesity is leading to alterations in memory, in immediate memory. We have studied a lot of cognitive domains in subjects with obesity. One of them is memory. Our research began more than 10 years ago using this small cohort in whom we evaluated 40 subjects submitted to MRI of the brain and also to evaluation of the gut microbiome composition. As expected, the biodiversity of this gut microbiome was affected by the total fat mass and the android fat mass and the levels of inflammation in our subjects. But what was unpredictable was that these actinobacteria, well, you can, this name is probably not very well known, but bifidobacterium is one of the main components of this, the phylum. So this bifidobacterium and this actinobacteria, what was surprising for us was that the abundance of this bifidobacterium was associated with the structure of the amygdala and with the structure of the striatum, or the thalamus in this case. How the abundance of a specific bacteria in our microbiota could be linked to this structure of this brain through a MRI. With this initial investigation, we focused systematically to address how the connection between the brain and the microbiome could be elicited. And we evaluated the composition of our subjects and several techniques, metagenomics and metabolomics, in depth to evaluate these relationships. And at the same time, we also collaborated with the group of Dr. Rafael Maldonado, that will be the next speaker, to evaluate how these findings translate into mice and to try to validate the findings. I'll always explain to my students that the microbiome is a type of black box in our body that is registering a lot of information, not only from the diet, but also the exposure to different drugs and the exposure to our emotions. I will talk about these three different components. First of one is the role of gut microbiome and memory. It was one of the first investigations that we performed. And it is very well known how the immediate memory is affecting subjects with obesity. This test, for instance, evaluates this memory, telling the subjects a list of 16 words classified in 4 semantic categories, and we repeat these different tests over 5 times. So the numbers of words that the subject remembers is the sum of the words is a score of this immediate memory. As predicted, subjects with obesity in our study saw it at decreased memory score. So it is well described, but we confirm it in our subjects. But what was impressive was that the microbiota was associated with this score of memory. You can see here on the right panel, on the right square, the bacteria that were positively associated with memory. So if we have an abundance of Ruminococcus, or Megasphaera, or Clostridium, or Pararhodospirillum, these were associated with increased memory. On the other hand, the bacterial species on the left, these proteobacteria with Bacteroides, Enterobacter, Citrobacter, all the abundance of these Salmonella and Klebsiella were negatively associated with this score. Well, this has, we have evaluated a lot of species, and even according to forced discovery rate, the association remains significant. But you can say, well, this could be by random. It is important to state that the associations were different in subjects with obesity on the right, or without obesity on the left. So, for instance, Bacterium were positively associated with memory in subjects with obesity. On the other hand, several Prevotella, here on the left, were also positively associated with memory in subjects without obesity. The next step was to evaluate the the volumes of the brain areas involved in these tests. For instance, we know that the left hippocampus is known to be correlated with the short-delayed pre-recall residuals. So this memory is The higher the volume of the hippocampus, the higher the test, the score in this test. On the other hand, the frontal inferior orbital right is known to be associated with this cognitive test that is total digit span. And the anterior cingulate cortex is also associated with this cognitive test. What was impressive is that the abundance of these bacterial species not only were associated with the score of the test, but also with the volume of the brain involved in this test. The same with frontal inferior orbital right, the same bacteria associated with the test, with this total digit span residuals was also linked to the volume of the brain area that is known to be affected by this test. And the same with these other tests. So the associations were not only with the cognitive tests, but also with the brain volumes that are known to be regulating these scores. The next step to validate this was to inoculate the fecal microbiota transplantation to mice and to evaluate memory in the recipient mice over a 4 weeks experiment. What was very exciting is to observe that the memory of the recipient mice, this novel object recognition for 24 hours, was associated with the memory of the donor. So the donor led to increased memory in the mice through the gut microbiota. Is this an infective disease? Memory is an infective trait that can be translated from human to mice through this gut microbiota. Interestingly, the subjects without obesity led to an increased memory of the mice compared to the control and with subjects with obesity. And this also observed that different microbiota led to associations with memory in the recipient mice. And another level of integration was to evaluate through RNA-seq the sequence of all genes in the prefrontal cortex that were linked to memory. And to our surprise, there was a kind of interrelationships between the expression of these genes involved with memory and the abundance of different bacterial species. So this confirmed again this link between the brain function and the gut microbiome. This was published 5 years ago, but we are talking about the role of gut bacterial microbiome on food addiction. Through this model that Rafael Maldonado, that will explain to you later, how he arrived to this, he could find several mice addicted to food through the intake of several food components. And in these food-addicted mice, there was an alteration in the persistence of response of motivation and compulsivity. But at the same time, he found that the abundance of several gut microbiome components of these mice was linked to this food addiction. You can see here how these phyla, families, and genera were specifically linked to addicted mice. And you can see here on the right how the abundance of this Plautia, of this genus, Plautia, was decreased in mice with food addiction. Well, this could be only an experiment, and this is a very peculiar experiment, but we are collaborating with him in several fields, and we try to replicate this in humans. And this is what we observe. In different cohorts of obese and non-obese subjects, the levels of this species, of Plautia species, were decreased according to the Yale food addiction score. So we confirm these observations in mice that Plautia, this very consistent genus that is found in every human that has been tested in the world, is one of the few bacteria that is very constant throughout the world, were decreased in subjects with food addiction. And we found that according to this jail food addiction score, the Blautia glucera, the Blautia zinci, and the Blautia vexillari were decreased with the increase in food addiction. The next step was to evaluate how could modulate the abundance of this Blautia. And this was obtained through the addition of lactulose and rhamnose in the diet of these mice. It is known that lactulose and rhamnose triggers an increase in the abundance of the Blautia. And interestingly, through the addition of these prebiotics in the diet of these mice led to an improved food addiction. And even in rhamnosa and lactulose group, no mouse was addicted. So we, to some extent, cured this food addiction simply by the addition of these prebiotics. These phenotypic traits dramatically improved only through this administration of this prebiotic. But the next step was to deliver not the prebiotic, but the Blautia itself. So to deliver the probiotic with a collaboration with a Japanese group that delivered us this bacteria that is very difficult to grow because it is anaerobic. So through the addiction of this Blautia, we also observe an improvement in food addiction, an improvement of motivation, an improvement of compulsivity, but not of the persistence of response. Again, the administration of this Blautia vexillari led to an important improvement of this food addiction of the different phenotypic traits. This was published last year in the journal Gut, and the last part of my presentation is related to the gut biome, not only with the gut bacteria present in our intestine, but also of the gut biome. This work was published in Nature Metabolism just 1 year ago, and we began here through the observations in humans. In this initial population, we observed that the jail food addiction score was increasing according to the level of obesity, or the level of fatness of our subjects. Not only this, but also we observed that one of the components of the microbiome, that was the abundance of these bacteriophages that is present inside the bacteria, the microbiote, the abundance of this microbiote was increased according to the jail food addiction score. So to some extent, addicted subjects to food displayed this increased abundance of microbiote. This was the initial explorative cohort. But we also evaluated that on a small initial cohort and found the abundance of microbiote was also altered in these subjects. When we evaluated the levels of motivation, persistence, and compulsivity according to this microbiote, you can see here how the increased microbiote was associated with the decreased motivation, persistence, mainly, but not of compulsivity. And this was also observed to the abundance of this Gokusovirus that is within this type of microbiote. So the abundance of Gokusovirus, that is the species, one of the species without this microbiote, was also linked to several traits of food addiction. We also evaluated in which bacteria were containing these viruses, and we found that one of the main candidates was Faecalibacterium prausnitzii. So the bacteria containing these viruses were probably linked to the development of food addiction. Well, these were the initial observations, but we tried to evaluate further different populations to confirm these results. And one of them was this validation cohort 2, the aging hemangiomics, that is subjects of the general population from here in Girona, more than 900 subjects, in whom we found again that the levels of microbiote increased with the level of obesity. In these subjects, we did not collect the jail food addiction score, But we collected a test that evaluates inhibitory control. It is well known that insufficient inhibitory control by the executive control network has shown to play a critical role in the shift from the homeostatic to hedonic regulatory food intake. So by improving the function, by improving the deficits in executive function, this has been suggested to mediate reward drive and craving, restoring control over addictive disorders. So this is the reason why we evaluated this test, this inhibitor control through the color word trial, the Stroop color word trial test. And we found again that the levels of microbiota were linked to a decreased inhibitor control. In parallel, this was in fact similar to what was found with the gel food addiction score. So with more microbiota and the poor the executive control. This was also again evaluated in a validation cohort 3, that is a different population in whom one subject of this population, the gel food addiction score was obtained. And again, in this third population, the levels of microbiota were linked to the gel food addiction score. We then tested which bacterial functions could be linked to this food addiction. You can see here how the different metabolites are transformed into dopamine and noradrenaline, and several of these bacterial functions were associated to the transformation of this L-dopa to dopamine. The next level of validation of our findings was to check what happened through fecal microbiome transplantation in mice. We evaluated cognitive flexibility in these mice, and we observed that the transplantation of the microbiota with the higher levels of goccusovirus and microbiota led to several traits of alterations in operant behavior, of alterations in impulsivity. So this fecal microbiota transplantation led to a phenotype that is reminiscent of food addiction. How this impulsivity could be elicited in mice simply by a transplantation of this food, of this gut microbiota. The last level of granularity, the last level of validation was to inoculate not the total fecal microbiota transplantation, but only the viral component of this fecal microbiota. This is obtained through a filtration of different tools to only obtain viruses, but not bacteria. And through the transplantation of these viruses from subjects with high addiction score, with high presence of goccusovirus, also led to a different phenotype with increased persistence, increased motivation, and increased compulsivity. So not only the fecal bacterial transplantation, but also the fecal viral transplantation elicited a similar phenotype, a phenotype of food addiction. With these transplanted mice, we evaluated which were the metabolites that were contained in the nucleus accumbens. And you can see here on the right part how these levels of enzymatic acid, pyridoxal, noradrenaline, tyrosine were increased in the nucleus accumbens of these mice. And to put in context what is the meaning of this observation was that evaluating where the pathways that were regulated by the transplantation of this fecal microbiota and fecal biome was that one of the first was the tyrosine metabolism. That is known, it is the metabolite that is leading to the synthesis of dopamine. So you can see here how different GABAergic synapse and amphetamine addiction and cocaine addiction were different metabolites involved in these pathways that were changed simply by the transplantation of the fecal microbiome. One of the metabolites that were more linked to this coccovirus and microbiota were precisely antranilic acid. You can see here through different artificial intelligence algorithms, we confirm that this antranilic acid in these two statistical complex relationships, where two of them, it was one of the metabolites most associated with the presence of this coccovirus. And this antranilic acid was decreased. So our hypothesis was that by delivering this antranilic acid, we could improve food addiction. And this was what we observed, that after experiment over a 1 month period, the addition of this antranilic acid led to changes in motivations and persistence, not of compulsivity, led to decreased impulsivity, but also led to a different abundance of the same antranilic acid of the metabolite that we are delivering in the diet of these mice, in the nucleus accumbens and in the dorsal striatum. When we analyzed the metabolites in these nucleus accumbens, we observed different abundance of these metabolites, specifically of antranilic acid here on the right, of hydroxyantranilic acid, that were the metabolites that we are delivering in the diet of these mice. So the take-home message of all this presentation is that the gut microbiome is playing probably a significant role in the development not only of different cognitive traits like memory and deficits in executive function, but also of alterations in the food addiction. And by manipulating these bacterial components of these metabolites or these viruses, we can significantly improve the food addiction and perhaps in the long term to decrease the risk of developing obesity. I would like to thank my team that were specifically involved in all these studies, specifically Anna Castells and Jordi Maneris-Persachs. And at the same time, I want to acknowledge the role of Dr. Rafael Maldonado, that will be the next speaker in this session, and of my colleagues in Barcelona and here in Girona, and also my colleagues in Valencia and Lleida that contributed to the analysis of several metagenomics and metabolomics presented here. Thank you very much for your attention.
Thank you very much for this very interesting presentation. Est-ce qu'il y a des questions dans la salle?
Are there any questions from the audience?
Do you think that ultra-processed food could have a direct effect on the disruption of microbiota that you have observed with the food addiction?
Yes, this is a very good question.
Oui, bien sûr, c'est une excellente question et précisément, nous travaillons sur le rôle de ces nourritures.
The initial observations are that the ultra-processed food leads to a very important change, a dramatic change in the gut microbiome, and of the several of these bacteria that we have presented here. So this will be the next paper that we are now elaborating.
Okay, thank you. Any other question? Maybe I have a last question. You have clearly shown the effect on cognition. Do you have also assessed the effect of the disruption of microbiote on emotional dimension, anxiety, depression, that are also very important dimensions that are associated to addiction and eating disorders?
Yes, yes. Thank you for your question. In fact, we published 3 years ago a paper showing how some components of the diet are leading to alterations in depressive traits. So we demonstrated how the proline that is present in several, for instance, chicken and gelatins, and even in ice cream. So this proline that is rich in these foods is eliciting a depressive trait. And we demonstrated here these observations in humans, in mice, and even we validated the findings in Drosophila. So it is clear that the food is modulating the composition of the microbiota, and in this context, is also modulating the depression. And we are now testing whether the decreased intake of proline in the diet can improve this depressive trait. This is the clinical trial that we are now just performing.
Very interesting. Another question?
Oui, bonjour, Maïbou Mengel, XAPAD.
Well, thank you. My name is Nigel Menchel from Versailles. To add up to this very interesting question, have you noticed from a clinical point of view elements that make that some patients may respond better to an alteration of their microbiome or less or to a potential reimplantation? Are these people who be maybe more or less anxious, more or less dysregulated, or these people who have higher or lower levels of craving? Do you have any clinical elements to support this answer?
I think that that's an important point. We need to modulate several traits using the changes in the microbiome. We could elicit them with changes in the probiotics and the prebiotics. At this stage, I think that the most plausible way to modulate the microbiome is the prebiotic. So given different components that trigger the growth of a specific bacteria that can be stable over time. Because through probiotics, the stability of this bacteria that we are adding in the food is probably low, so we need to replenish each day or each 2 to 3 days these bacteria, and we are not confident if this replenishment of bacteria will be stabilized in our microbiome, because this is a type of graft-to-host disease in the term that not all bacteria will establish in our microbiome. We are now studying which are the tools to change radically this microbiome in a positive way. But perhaps the most efficient tool now is the prebiotic, and not delivering the specific bacteria.
Okay, and do you have identified some clinical characteristics that could predict response to the intervention on microbiote? Like craving or anxiety, level of negative mood, for example?
Yes, well, this has been very poorly investigated in humans. So we have some characteristics in mice. It's very easy to control the conditions in mice. But in the real life, how can we anticipate the response to a specific probiotic or prebiotic? Is really very difficult. I am not aware of systematic studies addressing this question.
Okay, thank you very much. Merci beaucoup. Donc, je vous propose de passer à...
I suggest now we go on to the third presentation. I think we're well behind schedule. The third presentation is to be given by Professor Rafael Maldonado, who is a professor in Strasbourg and the University of Barcelona. And a lot of that work has been on animal models for addiction in a transdiagnostic way, and particularly disorder of eating. Today we have, he's recorded his presentation which is on an extremely important theme, and that is the the sex differences in food addiction. So this is a recorded video, and Professor Maldonado will be speaking to us through his film. Good morning. I'd like to thank the organizers first, and particularly Jean-Pierre Bercaise, for the invitation. I'm going to be talking to you about the influence of the sex in the development of food addiction. As you know, the term food addiction is a word which is perhaps rather polemical. First of all, it was defined by Randolph in 1956 as an impairment which some foods introduce in certain individuals which seem vulnerable. And this impairment is very similar to addiction to drugs. And the important thing, too, is not only the resemblance to drug addiction, but also there is an individual variability, which is enormous. And it will only develop with certain foods, and particularly those which are very calorie-rich, and it's very much linked to obesity. And if you look at the definition, food is not included in DSM-5. So we need to go to DSM-5 to look at the criteria for drug addiction, to try and perhaps bring together, if we want to use this term of addiction for food, see what the characteristics are. What are the most important characteristics? The most important characteristics of addiction to substances are persistence in seeking drugs. We can see persistence in looking for food, the motivation, and here we could have extreme motivation for food and compulsivity for taking drugs or for food, despite the negative effects that they may have. And it's no doubt a multifactorial illness, because it's not just the exposure to drugs and food, it's the influence of the environment. All this together will develop an impairment and changes in the brain which will modify behavior. So that's addiction. So to study the action with regard to food in animals, here this is with mice, we developed an addiction model using the Skinner's behavioral criteria. So we have a very long period, perhaps of 4 months, with a fixed ratio of 5. The mouse has to push the pedal 5 times to have just a little piece of food. And we're going to study the addiction criteria at the beginning and at the end. And at the end, we select those animals which are addicted with regard to those who are not. So here we can, to begin with, look at the influence of sex and the influence of any other factor involved in food addiction. We can study persistence, motivation, and compulsivity. Persistence first, because each session has a period of 25 minutes when it's active, 10 minutes when it's not active, and 25 minutes again when it's active. So the animal, between those 10 minutes where it's not active, the animal stops. But animals with persistence are going to continue to press the pedal to get food. Motivation. This means that for the first time, the animal is going to press the pedal to get the food. You just press it once. just to get a pellet of food. But you have to press 5 times and then 12 times, and then for the 5th time it's 60 times. So there's variety, so that you can measure what is the level of motivation that the animal has for this food. And compulsivity, we have a progression here. The animal has to press the pedal 5 times to have 1 pellet of food. If the animal presses 4 times, it gets an electric shock in its paws. If it presses the 5th time, a second electric shock, and then the food. So compulsivity can be measured. But there are certain characteristics of phenotype which are associated with addiction. Compulsivity during a period of 10 seconds when the mouse is pressing the pedal. The cognitive possibility, if you change an active pedal for an inactive pedal, and the association with a strengthening learning process where the animals has an inverse learning process. What happens with the mice in this addiction, with female mice? If we look at the influence of estrogens, we had a group where we carried out an ovarectomy, and we have healthy animals with all their hormones and animals where the ovaries had been removed, and so they have a very low level of these hormones. And you can see that the mice with low hormone levels or normal hormone levels, those who've had surgery or not, the healthy mice, they will press in similar ways to get the food. But if we look at mice who've developed addiction, about 35% are going to develop addiction. But in the female mice where we've removed the ovaries, 50% develop addiction, which is a much higher percentage. And if we compare this with males, these are mice. If we compare these males, we can see that female mice, 35% in the control group, developed addiction. In the males, 20%, much less. So our genetic background comes up to 25%, but there's always a percentage which is higher in females. So no doubt female mice, develop addiction more than males. And that depends on hormones, because if we remove the ovaries, then we have a lot more addiction. If we now compare the mice that have undergone surgery and healthy mice, and we look at animals who have developed addiction and separate them out from those who haven't developed addiction, we can see that there's a significant difference in the persistence of their response between the mice without ovaries when compared with the others. But in mice in the control group, these differences are significant in terms of motivation and compulsivity. So these hormones, no doubt, are important for all 3 criteria. And if we take healthy mice, we compare those that have the normal levels of hormones compared with those with low levels of hormones. Those who have low levels of estrogen have more persistence and more compulsivity and more motivation. And you can see the percentages. We can see very clearly the mice that have compulsivity, that's one of the criteria of addiction, is 45%. In those who have low estrogen levels, compared to 22 to those who have high estrogen levels. Motivation, 58% against 0, and persistence is not such a large difference. But we can see very clearly that the levels of estrogen are certainly linked with the development of these 3 signs of addiction. And with regard to the phenotypes, phenotypic traits, we can very clearly see a significant difference in terms of impulsivity in healthy and over-optimized mice. But in healthy mice, there's no difference in terms of impulsivity. There's some cognitive responses and also a difference to the adverse cue reactivity. In these animals, we've also studied anxiety in the classic models. We found that mice who have had the surgery have very low hormone levels are going to have an increase in anxiety. But in terms of depressive behavior, looking at the models of a tail suspension, we can see no major significant difference. So what are the components, if we look at a principal component analysis, what are the components which are going to have an influence on the development of addiction? On the sham mice and the mice without ovaries. On the sham mice, it's above all compulsivity. The mice who've had the surgery, it's motivation. There are different criteria which represent the most powerful component to determine the development of addiction. In these animals, we've also studied in the prefrontal cortex and in other areas of the brain the expression of certain genes of the dopaminergic receptors. And we can see NAC, and the most important modification is in the prefrontal cortex, where there is a reduction of the gene in the mice where we have removed the ovaries. And in mice where we've removed the ovaries, we also have a reduction in the DB. But in the central areas, it's not so involved in reinforcement. We can see an increase in the receptors, of the dopaminergic receptors. And there's also an increase in the DA receptors. However, in the hypothalamus, we found a very significant increase in mice without ovaries with regard to the expression of the cannabinoid receptors. And look at the receptors for alpha and beta estrogens and progesterone. We found an increase in the estrogen receptors and beta estrogen receptors in the prefrontal cortex in the mice whose ovaries had been removed. We also found an increase in the alpha estrogen receptors in the hypothalamus with a drastic reduction in the hormones in these mice. So if we compare this with humans, this is a comparison that we've done thanks to the cooperation with Professor Manuel Fernández-REAL, who has a very interesting cohort of women and men in which he had classified them, the men and women who were addicts or non-addicts to food, using the food addiction scale, the Yale food addiction scale, which is the clinical scale that's used to define food addiction. And we can find here, again, some very interesting results, which are very similar to those results that we get with mice. Because Manuel Fernández-REAL found that in women, and this is just women, the control women, 37% of women had a propensity to addiction, but amongst menopaused women with a reduction in estrogens, there were 54% who were vulnerable to the development of food addiction. And thanks to collaboration with Manuel Fernández-REAL, we were able to classify these women with high or low estrogen levels. And we can look at the high levels of estradiol, comparing control groups to menopausal women. But in young women before the menopause, we found high levels of estradiol which are associated with a significant reduction in the development of addiction. In women with low levels of estradiol, here we have all the menopausal women, but also the control in the control group, we can see a very interesting result, and that is that there is an increase in the development of addiction in menopausal women. We can find 60% of them who have a development of addiction, but also in women who are in the control group who have a low level of estradiol. So there's a very close link between the level of estradiol and the development of addiction. How conversely, with regard to other eating disorders, we found that in the binge eating disorder or anorexia nervosa, there's no modification, there's no correlation with these levels of estradiol. So Fernando Fernández-REAL found an increase in the level of estrogen with regard to the control group. That's with women who have obesity. If we look at principal component analysis to see what are the factors which are going to have a very powerful influence on the development of addiction, in the control group of women, it's above all motivation. And in menopausal women, it's above all craving. Those are the criteria. Motivation, we had that in the mice. We also had that in the mice. But it wasn't the most important thing. So there are certain similarities in this principal component analysis in humans and mice. So we can conclude that no doubt food addiction is higher in female mice than male mice, that low levels of estrogen may facilitate the development of food addiction in female mice, but also in women. And that these low levels of estrogen in mice were associated with changes in the expression of certain genes related with the dopaminergic system in the medial prefrontal cortex and the ventral and dorsal striatum and the cannabinoid system in the hypothalamus. These low levels of estrogens in mice were associated with enhanced estrogen receptors in the medial prefrontal cortex and the hypothalamus. And no doubt these changes in the expression of genes may facilitate understanding of the possible protective effects of estrogens in the development of food addiction. We need, of course, we need a lot more work to know more about this, but we can certainly see certain changes in the brains of mice which may be linked with this protective effect of estrogens. And of course, this is a collaborative research project with a lot of researchers, and this research group particularly wanted to thank Professor Martina Garcia, and particularly for the beginning of this study, and of course Professor Fernando Fernández-REAL from the Hospital of Velviche for studies on humans, Dr. José Manuel Fernández-REAL, Jordi Mañanes and Ana Castells, and Dr. Oscar Pozzo for all the animal studies. Thank you very much.
Bien, je vais passer maintenant la parole au docteur.
Now I'm going to hand over to the last speaker. Last speaker will be Professor Antonio VERDEJO. He's a professor of psychology at the University of Melbourne in Australia and has done a lot of work on neurocognitive factors in addiction according to a transdiagnostic approach. And he is going to be talking about neurocognitive factors in behavior and addiction with prospects in terms of possible therapeutic avenues.
Hello, everyone. First of all,
hello.
Hello. Can you hear me well?
Good morning. You can speak.
Thank you so much for troubleshooting, and thank you very much for the patience, and special thanks to the organizers for inviting me to talk. So I'm going to be chatting about mechanisms for food addiction and some of the interventions that could be applied from a neuropsychological perspective. I guess the problem we are trying to grapple with is this one. These are statistics from consumer surveys in Australia, but I assume it's pretty similar in Europe. At the moment, 50% of the weekly budget of Australian families is going into energy-dense and highly processed foods. So that's a disproportionate amount of money and consequently diet going into these type of foods. And I guess the reason why we are concerned about this type of foods is because akin to addiction, they have the ability to engage neural systems in the brain that go beyond homeostatic systems, and those include reward systems, represented here by the striatum and the anterior insula, systems including the amygdala and the hippocampus, and decision-making systems. And of course, they can interfere with these systems in ways that are different to what conventional foods would do, and they can also interfere with these systems in ways that they can generate or they can lead to the development of different health problems, and those include things like obesity, binge eating disorder, and what we tend to call food addiction. And there is a lot of overlap between all those different presentations. So in the next slide, what I'll show you is what is the approach that we have followed in many of the studies that I will be presenting today. So I will be presenting a few, but all of them are going to have in common this type of paradigm. So we do functional magnetic resonance imaging. So we try to study neural activation in response to different type of tasks and stimuli. But because in this case we're very interested in food, we had to develop this type of device that we call a gustometer, and this had to be all plastic, nothing metallic, to avoid getting stuck in the magnet, and then the university suing me for breaking the scanner. But basically you can see that the participant is lying down, and this device can be primed with different fluids. Some of them are going to be caloric fluids, some others, in some other manipulations, we're going to be looking into differences between energy-dense and highly processed foods and other foods that are considered healthier because they are lower in energy, they have more fiber, they have more natural components. And then, depending on the task, basically, people is going to receive one of those options, or is going to have to provide a response to tell us which of the options is going to receive. And then what we do is we deliver a small dose of that fluid into their mouths. And it has to be very gentle, of course, and it's about 3 ml that goes into the mouth because we have to avoid, again, people choking or having problems while they're lying down in the MRI. So we've been using this paradigm in different types of studies. So from now on, I will be explaining some of them. In the first one, I'm going to be focusing on the foods themselves, and then in some of the subsequent studies that I will be presenting afterwards, I'm going to be focusing in making systems in these clinical populations. But the first study that I'm going to be showing is a very small study that we did. You could consider a pilot study. And I did it in collaboration with these colleagues from the University of Sydney, Steve Simpson and David Bobenheimer. And they have developed this theory, which is based on a lot of ethological and ecological work in different species, which is called the nutritional geometry theory. So basically, the nutritional geometry assumptions are based on the observation that across many different species that go from insects to mammals to primates, like when, let's say, these animals are in their usual environment, and when they are interacting with that environment in a normal way, they tend to always have a balanced diet between the three main macronutrients, so between protein, carbohydrates, and fat. So the balance tends to be very similar, and they always tend to maintain that balance in a very stable way. Humans, like, there's no reason to believe we don't have the same ability, but one of the problems that we have is our environment is completely changed, and our environment is priming us to eat those macronutrients in completely different proportions. So what we did is they have ways of estimating different ratios of macronutrient that can be either balanced, or they can be severely unbalanced, or they can be kind of like disproportionately impacting the concentration of carbohydrates or fat. So that's what we did with them. They developed different mixes. So we had a control mix, which was basically relatively well balanced in terms of the macronutrient composition. And then we had a number of alternative mixes that were kind of like extreme forms of unbalanced ratios of protein, carbohydrates, and fat. And even though I say that they are extreme imbalanced versions of those products, like, we were basing these mixes in products that you can find every day in grocery shops and supermarkets. So they were reflecting the type of products that are present in modern supermarkets. And then we did a preparation period in which people had to do some learning and association between different cues, which in this case were geometrical figures, and the taste of those different drinks. And we did that before getting people into the fMRI scanner. And then we did a testing session in which we were delivering like each of those fluids inside the fMRI scanner, and we were seeing like what were the patterns of brain activation in comparison with the control drink. So basically the type of contrast that we were doing here in the brain was what happens when people are receiving these type of fluids that are clearly unbalanced in terms of their macronutrient composition, and they could be potentially addictive as compared to a fluid that is balanced in terms of the macronutrient composition. And it was interesting because at the brain level we found, even in a really small sample of participants, that those unbalanced fluids were capable of hyperactivating different regions of the brain in comparison to the neutral or the balanced drink. And we observed that for all the different fluids that were unbalanced, there was increased activation in the thalamus as compared to the neutral drink. And then there were some specific activations in the insula related to the high-fat drinks, and there were some specific activations in the striatum associated with the high-carbohydrate drinks. So to me, this was really persuasive evidence that some of these fluids that reflect like unbalanced macronutrient compositions, they can have an impact on the brain that goes beyond the impact that, let's say, a more balanced type of food or a more balanced type of diet could have. We were also assessing like some of the behavioral effects of these fluids, and both in the case of unbalanced high-fat fluids and in the case of unbalanced carbohydrate fluids, we noticed that they were significantly more liked. People were willing to pay more money for them as compared to the neutral Q, and people also reported that they had effects that were similar to those observed in stimulant drugs, not so much in opioid-like drugs. But it was interesting to have those results to show that they're kind of indicative that these food that we normally encounter in our daily life and that have this unbalanced macronutrient composition can have a very enticing effect on the brain and can engage brain systems way beyond the homeostatic circuit. And then in another set of studies, which are the ones that I'm going to be presenting in a second, like we wanted to examine a little bit more this conflict that we experience in daily life, where we are constantly faced with choices between some foods that look potentially more appealing and rewarding in the short term and can actually can have like some short term, and some other options that can be maybe not so appealing in the short term, but clearly are healthier in the long term. So we wanted to have this type of fMRI experiments where we put people in this conflict between choosing healthy or unhealthy foods. And of course, we wanted to do same as we had done before, using actual physiological stimuli, so in this case, fluids. And we wanted to study things both in fasting and satiety conditions. And especially we were interested in analyzing how the effects were moderated by adiposity, so especially like people with higher BMIs, people with overweight and obesity, and also in relation to binge eating, so in people with binge eating disorder. So this is the task that we used inside the fMRI scanner. So we basically present a choice, a binary choice between two different options. So in this case, it was either a veggie juice or a lovely milkshake. And we had different versions of the milkshake that were obviously way more energy dense, and they had some ultra-processed elements like syrup and added sugars and all of that. So the stimuli are first presented, and then people have some time to compute the value of those options. And then we have a fixation cross, and then a second phase in which people have to actually implement the choice. So they have to choose which one they want. And then we have a third phase in which we just deliver the fluid inside their tongue, and we can analyze what is happening during that delivery phase. And one of the first things that we realized when we put people through this task is that these type of choices between healthy and unhealthy products, they generate a great deal of activation in the brain. They are difficult dilemmas to solve for the brain. And you can see here the general pattern of activations that you observe, and you can see activations both in prefrontal cortical regions and also posterior cortical regions in the parietal cortex and the precuneus. And you cannot see it in here, but there was significant activation in the insula, the striatum, and the hypothalamus. So there is a broad network activation associated with this type of decision between healthy and unhealthy products. And we were specifically interested in this large functional region in the brain, which we call the ventromedial prefrontal cortex. And we were very interested in that region because it's very important for computing the relative value of different options and valuing those options and guiding decision making based on the relative value that different things have. So in some ways you can think about the ventromedial prefrontal cortex as something similar like to a stock market board, in which you can see the value of different companies and you can see their relative value, and therefore like based on that you can make investment decisions. So we were particularly interested in that, and we actually found some interesting results, both in relation to the homeostatic state of participants in the experiment and also as a function of BMI. So we found that the ventromedial prefrontal cortex was significantly more activated when people were hungry as compared to when they were sated. And we also found that people with higher BMIs also had increased ventromedial prefrontal cortex activation when they were making these type of decisions between unhealthy and healthy food products. So that made us think that in some ways the ventromedial prefrontal cortex was oversensitized, or was kind of like computing like different elements of the evaluation process, including probably like some motivational or reward related and hedonic related computational mechanisms. And what we did is we analyzed a little bit more what was the connectivity that was emerging from the ventromedial prefrontal cortex. So in this case, rather than thinking about what areas in the brain are activated, what we were looking at is how different areas of the brain were communicating with each other when people were making these type of decisions between healthy and unhealthy products. And what we found was very interesting. We found that in people with greater BMI, so people with overweight and obesity, there was less functional connectivity between the ventromedial prefrontal cortex and the hypothalamus. And the way that we interpret this is that in normal circumstances, when you're making those complex decisions about food, you would like to have a good communication between the regions of the brain that are computing the value and the reward appeal of different options, and the regions of the brain that are computing the homeostatic needs that you have at that particular moment. But what happened in people with overweight and obesity is that that communication was disrupted. So there was less information sharing between value-based systems and homeostatic-based systems, specifically when people were hungry. So that gave us an idea that there were some significant alterations in the way the brain computes these type of decisions in people with overweight and obesity. Then more recently, what we did is to try to replicate those studies in a different population, in a population of people with binge eating disorder. And interestingly, we have found very similar results to the ones that we found in the case of obesity. So we have found that during this conflict between healthy and unhealthy choices, people with greater binge eating symptomology, they show increased activation in quite distributed regions of the ventromedial prefrontal cortex and the anterior cingulate. And you can see also increased activation at the level of the ventral striatum and the hypothalamus. So clearly, the ventromedial prefrontal cortex and these other reward-related regions are signaling some of the pathophysiology associated with obesity and binge eating disorder in the context of decision-making. Another really cool thing that you can do with this type of paradigm is that you can very nicely dissociate the anticipation stage of decision making. So when people are considering the options and computing the value of the different options, from the consumption stage of decision making. So when people has already chosen something and they are just receiving that that fluid and they are tasting that fluid. And of course, we thought that we could potentially like find dissociated neural systems associated with each of those phases. So we deconvoluted the signal or segregated the signal associated with the initial decision phase and the posterior delivery phase, and we found actually that different brain regions were more activated in each of those phases. So we had the anterior cingulate cortex and some of the regions of the executive system activated during the decision phase, but then we had the ventromedial prefrontal cortex significantly activated during the actual consumption of the fluid. So during the more consumatory or the more hedonic phase of decision making. And then of course what we tried to do is we tried to analyze whether people with overweight and obesity would have differential response across those different phases. And what we found is that during the initial period of decision making, there were negative associations between BMI and the activation of the executive function network. So you can see that the greater the BMI, the lesser the activation of the dorsolateral prefrontal cortex, the dorsal anterior cingulate, and also in other regions in the parietal cortex and the insula. So what we interpret here is that the greater the BMI, the lower engagement of the executive network when making this type of decisions between healthy and unhealthy food. But the interesting thing, though, and probably you will find this appealing from an addiction perspective, is that people with greater BMI also had less consumption-related liking signals in the ventromedial prefrontal cortex. So even though they were choosing things that they're supposed to like, they were highly motivated for, like the greater the BMI, the lower the activation of the ventromedial prefrontal cortex when they were actually receiving that fluid. And to us, this was kind of like suggestive of the dissociation that has been described in people with addiction between wanting and liking, right? Like we could see an increased sensitization to many of these foods and products, but once people receive those products, in the case of people with obesity, it doesn't seem like they're getting the type of hedonic related reactivity that you would expect. We have also been playing with the gustometer in different contexts. So one of the things that we've been playing with is, okay, if some of these neural systems are implicated both in binge eating and other type of binges, like for example, the ones that you observe in addiction, there should be some type of cross-sensitization between food and diet and other drug-related rewards, like for example, alcohol, right? So we designed this experiment in which we were bringing people to the lab and we were randomly allocating them to either receive an energy-dense breakfast or a healthy breakfast. And then immediately after the breakfast, they were going into the fMRI scanner and they were doing a reaction time task in which they were trying to react to a cue to obtain a sip of beer. So basically, like after the dietary manipulation, so after exposing them to either a high energy for a breakfast or a low energy breakfast, they were doing a reaction time task to be able to get some beer inside the scanner. So we always have problems recruiting people. Like we didn't have any problem recruiting people for this study. It was very popular in campus. And when we analyzed the behavioral data, we could see some evidence that could be suggestive of that type of cross-sensitization. So we saw that people that had consumed the high energy meal, they were more quick in trying to get their beer. So they were significantly faster in the reaction time task to try to get their sip of beer. But on the other hand, when we're analyzing the brain data, like we found like very consistent patterns of activation during the task in both groups, but we didn't see significant differences between the high energy breakfast group and the low energy breakfast group in terms of patterns of brain activation. So then we thought, okay, it doesn't look like an acute dietary manipulation is sufficiently powered as to engage differential neural systems in response to alcohol. But what if we look into more kind of like stable, long-term dietary habits? And then we were looking into a very detailed dietary diary that they had been doing for about a month. And then we were analyzing correlations between the degree of exposure to, for example, in this case, it was like the percentage of kilojoules that they were getting from saturated fat and some of the patterns of brain activation in response to beer. and we observed some significant correlations between the amount of fat that they were getting in their diet and the patterns of activation in the dorsal striatum in response to the drink. So in some ways, we were seeing some evidence of potential relationships between patterns of dietary consumption and response to other type of rewards, in this case, alcohol-related rewards. So I'm going to slightly change gears for the last few slides of the presentation, and I'm going to show you some data about what are predictors of food addiction, in particular in adolescents, and what can be some of the efforts that can be done in the context of treating food addiction. So now, rather than studying participants with overweight or obesity or with binge eating disorder, we were basically measuring food addiction symptoms in the way that is traditionally done, so with the WIFA scale. The first study that I'm going to be showing to you is this study on predictors of food addiction in adolescents. And this was done in a sample, a nationally representative sample of Australian adolescents with a mean age of about 13 years old. And the sample size was something like over 6,000. So it's a really large, a highly representative sample of the Australian population. And basically we were analyzing some of the psychological and lifestyle variables that were related with the emergence of food addiction in adolescents. And here you can see some of the results of the prediction models, of the regression models, and you can see, interestingly, how things like sleep quality, having been the victim of bullying, and self-control characteristics, so lower self-control, were significant predictors of the emergence of food addiction even during these early stages of life. And again, this is an interesting parallel with traditional substance addictions, right? Where we know that both trauma, low self-control, and high levels of impulsivity are also longitudinal predictors of escalation into drug use and development of substance use disorders. So this was also interesting and sobering in terms of realizing that many of the drivers of substance addictions could also be significantly impacting the emergence of food addiction in children and adolescents. And the last thing I'm going to show you is what can we do about it. So in this case, this is a clinical trial that we designed to test a telehealth intervention that was specifically targeted to food addiction. So by way of context, I would say that even before COVID, telehealth was increasingly popular in Australia because it's such a big country that many people don't have the possibility of accessing traditional health services. So we thought that this would be an interesting platform to try a targeted intervention for food addiction. And we did it across 3 different arms. One was an active arm in which people were in contact with a therapist and were doing these different therapeutic modules. Another one was a passive arm in which people were exposed to the same contents, but they didn't have contact with the therapist, and then we had a wait list control. And the intervention was a personalized intervention, so we did some assessment of some of the traits that are associated with food addiction, including impulsivity, emotion regulation, etc. And then we were tailoring many of the contents to the particular profile of the individual. There were several elements of the intervention. Some of them were more cognitively related, for example, helping people creating and managing goals, controlling overeating, regulating their mood. But we also introduced some very practical trainings. For example, we were using this training that it's called No Money, No Time. And this is a training that is intended to teach people how to cook with healthy ingredients that are cheap. As you know, one of the problems with healthy food versus potentially unhealthy food is that unhealthy food tends to be way cheaper and way easier to prepare. So what we were trying to do here is to counter that by teaching people how to identify healthy food that is cheap and that they could use to cook and being able to improve their dietary habits with a little bit of help. And then what you can see in here is how the symptoms of food addiction were reducing over time in different groups. So it is color-coded, so the red is where people were in the severe end of the spectrum of food addiction, and then you can see progressively the mild and so the mild is in green and the low is in blue. So you can see how in the active arm, which is in the one that you have on the left side of the graph, people were transitioning between severe forms of food addiction and really mild or negligible forms of food addiction. Interestingly, when people were exposed to the same content but they didn't have any interaction with the therapist, we didn't observe the same effect. So there was something related to the active ingredients of the intervention, but there was also something related to the contact with the therapist that really helped people to improve their food addiction symptoms. It was interesting because it's a relatively simple, low-friction intervention. People can do it from home, and it had positive effects and also a very good longevity of effects. So the effects were still significant after 6 months post-intervention. So hopefully I gave you a good sense of the potentially different drivers of food addiction, including some of the macronutrient composition of food, energy density, and how that interact with different decision-making systems in the brain. There's many challenges in this area, like one of them is developing truly biopsychosocial treatments to try to manage some of these presentations. We're very interested as well in combination therapies and step care approaches, and at the moment we're doing a SMART trial in which we are combining cognitive behavioral therapy with transcranial magnetic stimulation to try to reduce some of the binging symptoms of binge eating spectrum disorders. But there's, of course, important policy implications that would definitely impact or make a difference in this area. One of them is access to specialized treatments. One of the main problems for people with food addiction or binge eating disorder is that they are significantly underdiagnosed and undertreated. It's only a very low proportion of people that would seek treatment. And even the people who would seek treatment, they wouldn't have a lot of options. So I think like increasing access to specialized treatment is one of the key elements of making positive change. Then, of course, like there is some debate and interesting ideas around labeling and taxating ultra-processed food. And that has had some positive effects in some countries that have implemented those type of policies, and obviously a lot to do as well in terms of reshaping obesogenic environment and culture. So that was it. I was trying to be quick because I assume that you guys are craving for coffee at this stage, but I wanted to hang in there for a second with this acknowledgement slide to recognize the work of many people who have been involved in these studies and have made this research possible, and also to our funders, including the Australian Eating Disorders Research and Translation Centre, which is a national initiative to find novel pathways and novel treatments for people with different eating disorders. So thank you very much for the attention and the patience, and yeah, happy to take questions.
Yeah. Merci beaucoup, thank you very much. Je suis désolée, on va être dans l'obligation de...
I'm sorry, but we will have to close this session because we're running late. So we have really understood, well, the interest of early screening and implementation of prevention action that would be very efficient, effective to try and limit and manage addictive behavior. and avoid the addiction, other forms of addiction to substances.
We have overpassed the time, and we have another session that will be done now. Donc, thank you very much.
Thank you.